Hello, I'm Bob Challoner, the President and CEO of Southampton Hospital, and I would like to welcome you to another edition of Focus on Southampton Hospital, your monthly television program about the events and happenings at your community hospital. Today we're going to do something a little bit different. We're going to welcome a member of our management team here who's the director of our pharmacy, a very, very important role at the hospital. And one of those departments that frequently patients and visitors don't get to see. But when you think about all of the healing processes and the amount of medication that is prescribed and managed on a daily basis and the complexity of managing all those medications in a hospital, it's a vital role for us, and we have a full department here which we'll learn about. And I'd like to welcome today the director of our department, Jerard West, Dr. Jerard West, actually, correct?
Thank you.
Jerry, tell me a little bit about yourself first. Let's hear about your background and, and how you ended up all the way out here in the East End. So.
Well, it's a pleasure to be here. Thank you, Bob. I'm the director of pharmacy. I've been here at Southampton Hospital as the director of pharmacy for 5 years, coming this September. I've been a pharmacist now for almost 18 years. I'm a graduate of St. John's University, where I received my bachelor's degree in pharmacy sciences.
Go Big Red or whatever. Right.
And then I went back to school back in 2001 to get my PharmD, my doctorate degree, at St. John's University as well. I've always been working in hospital pharmacy. It seemed to be my love and my passion, and the clinical aspects which come with pharmacy. That's where I always was geared to. And over a period of time, I worked at various hospitals, Mercy Medical Center, Good Samaritan Hospital, and 5 years ago I came here to Southampton.
And the level of education that you have, which is, how many years is that altogether? I was kind of losing track.
Well, it's changed over the years. Currently, at the time when I went to school, my undergrad was 5 years, and I did my doctorate. It took me part-time while working full-time, but I went to school part-time. It took me 3 years, so I have a total of 8 years of education. Wow, currently, right now, if you have new pharmacy students that go through the program, they go through straight 6 years, but they do it full-time straight through, and they get it in 6 years.
And is it typical for people to get a doctorate at this point? Is that
yes, and that's what it's geared to. It's all about being clinical, taking your education to a higher level, and that was the focus of why I went back. I didn't want to miss out. Most of the time, the graduates just got their bachelor's of science and they went out and worked in the community or in the hospital. But now there's more medications coming out, there's all this new technology, and also being more clinical, which is really important, and about giving medications and patient safety, the doctorate is preferred.
Yeah, I've got to think that staying abreast of all the changes in medication must be a full-time ongoing education for pharmacists these days. It seems like every day there's some new medication that's being released.
You know, and not only are there new medications coming out every day, in conjunction with that, the technology and the topics of meaningful use and the computerization, barcoding, especially in a hospital pharmacy, it's a tremendous job.
Yeah, it's a huge job, and we're going to learn a little bit about what's going on here at Southampton. But we've been through at the hospital a number of major changes in pharmacy over the last really couple of years, and the biggest change recently was the implementation of the Siemens computer system, electronic record, which also has a pharmacy aspect to it. Tell us a little bit about that.
Okay, just a brief summary. The Siemens pharmacy system is one of 3 parts of the total new computer system that was implemented at the beginning of this past April. You have Saurian Clinicals, which is the physician component, where you have physicians having the capability of doing computerized physician order entry, an acronym CPOE orders. Then you have the second component, which is the nursing component, which is the medication administration check, an acronym MAC, which they call that. Where the nurses have an actual computer system where it kind of tells them what medications are due at specific times, and it gives them their work list that they work off of, and they have their medications which they're supposed to administer at specific times to the patient. In addition to administering and documenting the administering of those medications, there are other vital signs and other information related to medications which they can input on that system. And then the last component, obviously, is Siemens Pharmacy, and it's the bridge between those other two systems. So as a general overview, you have a physician entering medication orders in Saurian Clinicals via CPOE, and that gets transcribed and sent to Siemens Pharmacy, where the pharmacist then validates those orders, make sure everything is correct for the patient, for the disease state. It has all the elements of an actual order, and it makes sure there's no issues with drug interactions, etc. And then once it's validated by the pharmacist, it then gets sent over to the nurse system. And the nurse will see it, will verify it against the physician's order, and that's another safety check. And then it goes to the actual medication administration, which there are other safety checks involved with barcoding.
And a major reason I know for implementing all of these computer systems, I think it was in 2009 or so, there was a report released on the number of mistakes, frankly, that are made in hospitals every year, and a number of those mistakes are related to drug interactions.
Absolutely.
And a major push now is to get the physician ordering directly. What's the purpose of that? Why are we so worried about whether or not the physician's ordering directly or not?
Okay, with the technology and the invention of the computer, we have the capabilities of coming up with, they call it PCOs, predefined common orders. So when you think about how a physician would in the past write an order, they would actually write it on a piece of paper, okay? And they would have to write all the different elements of a prescription: the drug, name, the dose, the frequency, the medication, any special instructions. A lot of the program and development of the new computer system, pharmacy was involved with developing all these predefined common orders. So when a physician goes and decides to place an order on a patient, these predefined common orders are available to him to just select. And with that being said, once he does that and sends it over to the pharmacy system to be validated, the pharmacist doesn't have to take the time and transcribe them, or you're looking at handwriting issues. That's been all absolved from this new
big problem in the past, right?
In the past, absolutely.
Sometimes made a mistake because you couldn't recognize the handwriting.
In addition to that, the resources for information are at the fingertips now, not only of physician and nursing, but also as a pharmacist in the new computer system. It is updated by First Data Bank, which is a big resourceful information about medications, and all the information for the prescription is already there for the pharmacist, so they can spend more time looking at these resources to make sure everything's appropriate before it's actually validated, and the turnaround time is much quicker and it's efficient.
So the pharmacist is then doing a quality check, I guess, as well on the actual order coming in from the physician.
Absolutely.
And I would assume that pharmacists, I know the relationship, I've heard doctors talk about having a good, strong partnership with the pharmacist is vital, because the pharmacists really specialize in all these medications and are probably much more abreast of the various dosing and interactions and things. So I would think that would be helpful.
The dynamic with the physicians and also with the nurses, with the hospital pharmacists, it's a little bit different. You always think, obviously, patients are they're our customers. They are the heart of the hospital. But if you think about the pharmacists in general, you always think, is the patient coming into a retail pharmacy, okay? So the second layer of our customers from a hospital pharmacy perspective is the physician and also the nurse, and we work together as a team.
That's wonderful. And so when an order's placed, what are the typical things that you're looking for? It's not just, I know that I may have an allergy. Are there other sorts of things like a penicillin? I don't, but I've heard people say they're allergic to penicillin.
Yes.
What are the kinds of things that you're typically looking for when you get a drug order?
When you get a drug order, and with our new computer system, one of the first things you establish is making sure you have the correct patient demographics, and one of them is also to the type of patient, whether it's a pediatric or a geriatric patient. You also want to take a look at the allergies. And that's very important because the system forces the pharmacy to validate or code the allergies in the system. And that's very important depending on what drug is coming over, being prescribed and ordered by the physician. Once that's validated and you're saying that that's the patient's drug allergy and you're verifying it, it will actually catch any type of contraindications depending upon what medication it is ordered. So that's very important. So allergies are the first things that you usually look at, and looking at the patient's demographics. Secondly, the system has the capability of looking at the different medications that are on the patient profile and then the new medications that are being prescribed, and it actually will do drug interactions, and that's very important.
Do you have an example of something like that, or?
A drug interaction could be, say a doctor's ordering an antibiotic. An antibiotic can affect the metabolism if the patient's also on a blood thinner, say for example Coumadin.
Okay.
And there's different classifications of drug interactions, and the more severe ones will actually, first of all, alert the pharmacist, so the pharmacist can then contact the doctor. Or after contacting the doctor, if they still want to say, okay, still give the medication, but we're going to monitor the patient more closely, all that information in the computer system is documented to show that, yes, we documented there was a drug interaction, but we're just going to monitor the patient more closely.
Okay, so there may be times when there might be an interaction, but it's still the benefit of potentially those two medications that outweighs it.
And certain drug interactions are okay, and actually they work together synergistically and actually benefit the patient. But depending on the classification, how severe they are, if it's detrimental or not to the patient, everything in the computer system is documented, and it shows a story of the patient and their drug history.
And what about age? I've heard that in the past there was always a concern kids are different.
Yes.
So how does the system work from an
Absolutely.
age perspective?
Depending on their metabolism and how drugs affect different patient populations, pediatric versus adults and even geriatrics, the sensitivity are different among the age populations. And with that being said, and with the new computer system, my pharmacy staff, supported by my assistant director, my informatics supervisor, who are a very important part of the development of the program, we spent a lot of time looking at different dosages, min-max dosages. So if you have a pediatric patient, you have a certain drug, we put these limits in the computer system to flag, to say, you are reaching a max dose, or maybe it's a subtherapeutic dose where you have to adjust the dose and contact the doctor and say, listen, this is incorrect for that specific patient.
So are there any drugs that might be inappropriate at different ages for kids, say, that the system would catch that as well?
Absolutely. Certain classes of medications, for example, quinolones, which are antibiotics, which really should not be used in a pediatric population or just under very extreme or severe circumstances, it will actually send a warning that it has to be monitored and take a look at whether or not the doctor wants to continue that medication. Another example would be with a medication that's teratogenic with a pregnant patient.
What's teratogenic mean?
Teratogenic, it would cause harm to the fetus in the development. Okay. And so that would also flag as well. So if we have a patient that is pregnant, that would flag, and a warning alert would come across.
And stop right up front.
Exactly.
And does the physician actually have a chance to see those flags right up front as they're ordering?
Yes. As for a fact, when we were talking about allergies, let's say he ordered a penicillin antibiotic or a form of a penicillin derivative, and the patient was allergic to penicillin, it will come up and it will warn them. And there's certain circumstances where the physician would want to continue it or DC it and choose a different class of antibiotic. So they get alerted as well.
And I'm assuming there'd be protections for things like overdosing, and there have been some instances in healthcare in the past of a physician ordering just too large a dose.
Absolutely. There have been, with the new computer system, min-max dose checking for certain drugs that are set up in a way that you know when it is an outside of range, it's a high dose or subtherapeutic dose.
And Jerry, there's all these, in addition to the ordering in the computer, we've implemented a number of other pieces of technology as well that are all designed, I know, primarily around patient safety.
Yes.
One of those things is barcoding. So now patients actually have barcodes on their bands, and the medications have barcoding. What's the point of barcode? I know in a supermarket where you're checking things out, but what's the point for barcoding in hospitals?
Barcoding technology, especially in hospitals, it's a tremendous project. It's an exciting project, and it's really a good feature that enhances patient safety. We have a lot of unit dose medications, meaning they come in individual packet size that come directly from the distributor with manufacturer barcodes on them. But there are other medications that we buy in bulk in the hospital pharmacy that we actually have to unit dose and place barcodes on them. With that being said, there's a lot of liability with that. We have to ensure that whatever we barcode in unit dose is that drug, because once we barcode it and unit dose that medication, we are saying that if it's aspirin 81 milligrams and we slap that barcode on it, that it is. So with that being said, we had to come up with a big plan, policy, and procedure, and actually go over it with the staff of how do we ensure that we're doing barcoding appropriately. So why is barcoding such an important part? Well, in the scheme of things, in the administration of medications to patients, medications will go up to the floors, and a nurse will actually go to her active work list in MAC, which is the Medication Administration Check, and the time to give her medication. She will scan the patient, so we're also scanning the patient at the bedside to make sure that they have the correct patient, and it links it into the patient profile.
And they're scanning their armband.
They're scanning their armband,
I don't want
yes,
people
they
to
are.
think we're
Scanning the whole body.
Scans.
They're scanning their armband, and then they're going over to the computer system, and they have the medication that they're supposed to give. And then they click onto it that they're going to administer it, and they take the medication, which is barcoded, and they scan the barcode on that unit dose. Okay. And at that point in time, if it's the wrong drug, not matched up with the right patient, it will have a big X on the screen, and it forces the nurse to stop. Okay. Whether it's a technology issue, whether it's something wrong with the barcode, or there may be a true mistake that it's the incorrect drug for the patient, and that's where the safety comes into play.
And that's done for every medication administration at this point on the floor?
Yes.
Okay.
That only includes oral medication, also includes the intravenous IV medication as well.
Okay. So all of that's checking the right patient, right drug, right
Correct.
time, I guess,
yes.
as well. And does that simplify some of the documentation then for the staff?
It is. It's a big challenge, and
right.
because everything now is real time. It's very efficient, and it's a timestamp. Right. Exactly what you just said, and it tells a story whether or not there's an issue. And there are times when there should be delays in the medication administration if the patient's off the floor of a test, and there are contingency plans that when a nurse has to give a med and the patient's off the floor, that they can say, okay, patient was off the floor, because you don't want to have it that nurses are not giving medications on time, because we have standard times of administration. But it tells a story of the patient while they're here at the hospital.
Much easier, I would think, to guard against just human forgetfulness, or sometimes in the heat of the moment, nurses
yes.
trying to do 6 things at once and may forget, did I actually give that medication or not? Now they've
yes.
got the ability to look that up.
Yes.
So.
And with that barcoding of medication, another issue which comes into play is you hear of all these different drug recalls. Okay. And when you have recalls, from the wholesaler will contact the hospital pharmacy and say, hey, you've purchased these certain medications with specific lot numbers, which tracks certain medications that they may have a problem with, which needs to be recalled. In the past, when we got those notices, we could only look at the lot numbers that we have here in the hospital. With barcoding technology, if there is an issue or a question or a concern, we can even track that, because when they administer that patient with the barcode of the medication, we can track it to which patients got that medication if that lot number was questioned.
So if necessary, we could contact all those patients
exactly.
and say there's been a recall or whatever.
So that's a really true important safety feature.
That's a tremendous safety issue. The barcodes are on medication carts that are in use on the floors, and I know there's something that we're now doing, the daily cart fill process. And that also is a safety feature
yes.
in terms of medication availability. Talk to me about that a little bit.
We went a few months ago with the daily cart fill.
And the carts, so that people know what we're
Right.
talking about, the carts are.
The medication carts on the floors, on the nursing units, have individual patient-specific drawers. And they receive oral medications for their standing orders that they're supposed to receive once, twice, or 3 times a day. Now we have a daily medication cart fill. So in the pharmacy department, we do an exchange. We actually have a second set of cassettes down in the pharmacy department where we run, and with the new computer system, we have the capability of printing out which oral medications the patients are on a daily basis, and we fill a 24-hour supply. And we exchange that every day. And the safety feature is that there's less medication in the patient's drawers for that patient, moving from, say, filling it every 3 days to once a day. It's more current, and more importantly, with less medications available that mistakenly the nurse could give to the patient in error, that is a tremendous safety issue.
I would think it would also be, there's some other safety aspects too. There's just less medications floating around on the floor.
Absolutely.
That might be a temptation for somebody to abuse, or even just from a cost perspective, it'd be easier to manage the cost of the medications.
And everything is done in real time then, because they have exactly what they need for that 24-hour period.
For that time period. And there are protocols, I would assume, emergencies happen, and
Absolutely.
a patient doesn't have the, medication may not be in the cart. What happens then if an emergency?
We have automated dispensing machines that are located on every nursing unit that have medications stocked in them in the medication rooms, and they have lists of different units. They have lists of medications which can be taken out in a stat emergent situation where they wouldn't have to wait for pharmacy to bring it up. They can just go to the Pyxis machine, and it has. The machines themselves actually have a user ID, and they have biotechnology. They have a fingerprint for the specific user, and they can take out medications during the stat emergent situations, and we can track that by reporting to make sure that it is appropriate.
And by
during
who's
those
taking
situations.
out
And
the
you know
medicine.
who took it out at what time on the specific patient, and if it's a controlled substance, you can even tailor it who ordered that controlled substance as well.
So an unauthorized person would be very
Exactly.
unlikely to be able to access this equipment.
That's correct.
We've made a number of other changes recently, including we're doing some work in the pharmacy as the world of pharmacy is changing, and one of those big changes recently was remodeling, refurbishing our IV room.
Yes.
What was all of that about, and why? And again, it's all linked to patient safety.
Yeah. With the IV room, we completed it this past March, right before we went live with the computer system. It was a great project to be part of. We had an IV room that over the years has been used over and over again, and it was time to be renovated. And it couldn't come at a better time. Just in the past 2 years, we've seen that in preparation of IV medications, this hospital pharmacy and other hospital pharmacies had to increase their workload, making more IV preparations due to the closure of the outsourcing compounding pharmacies. So with that being...
What were those outsourcing compounding pharmacies?
There were these compounding pharmacies that would prepare standardized medication for hospitals at certain concentrations, and they were batching them and preparing them in their IV rooms in their compounding areas.
So they were pre-mixing.
They were pre-mixing it and selling it to the hospitals.
Okay.
With that being said, the hospital will receive these medications, and if you have a smaller staff or if you're a busy institution, instead of stopping the pharmacist and preparing these specific IV preparations, they would use these that are bought and associated not only with safety issues. These companies would actually charge the hospitals quite a bit of extravagant money because you're saving time,
right,
and they're all prepared beforehand. And they would have these long expiration dates, so the stability data was there. Unfortunately, there was some issues with the actual rooms themselves, with the environment that they were making these compounds in, and they weren't up to 797 standards, which is the ideal environment that you want to prepare IV compounds in.
This is for sterility.
The sterility, aseptic technique, that the FDA came down hard on these outsourcing companies and closed them.
Okay.
So we had, hospital pharmacies had no choice but to make sure that we were doing not only a good job in preparing our IVs, but making sure the physical component of the IV room, especially when the Joint Commission comes, which is the accrediting body of the hospital, to making sure we were all doing the right thing in there. And the IV room, we wound up getting, talking about making compounds in a sterile environment. We put a solid ceiling in the IV room. Any carts that were supplying it that had medications in the IV room were wipe down carts, or special carts they would use in a sterile OR environment, so we purchased them. The ante room, which is the room prior to the IV compounding room, that room, we thought about the workload and the design to make sure we could spread out not only the medications before going into the IV room. We also, a spot for where the technician could look at computer orders and validate what's going in the IV room is correct. In addition to that, we got a hands-free sink, so when the pharmacist or the technician goes in the IV room to prepare an IV, they have to gown up and put gloves on, and they wouldn't have to touch faucets before going into the clean room, which was a nice touch in the improvements in the IV room.
It really sounds like going into surgery almost.
It really is. Then that's the type
of
environment you want, and,
Right.
and making that IV room as aseptic as can be to try to reach those 797 standards, which are very important in preparing sterile IV compounds.
Excellent. And I know there's even air control hoods and things in there for mixing to
Correct.
protect the medications, the patients, and the staff even. Some of the substances I know are hazardous to staff if they're not
We have a
handled
different
correctly.
type of hood for that. We have a biological safety hood. So when the pharmacists are preparing, say, oncology products, that when they're preparing the medications inside the hood, that the air to keep the medication sterile doesn't come out towards the user. It goes out through the exhaust throughout the hospital.
Right. And I know there's some plans to renovate the entire pharmacy. We're making,
Yes, we're-
adapting the entire, because I guess with technology changing and
Yes.
medications changing, we need to change the total environment.
The entire pharmacy staff is totally thrilled about even consideration of doing a whole pharmacy renovation starting this fall. My assistant director and myself visited various hospitals, hospital pharmacies, because the key component is optimum workflow and doing things in the right environment to prevent any possible medication errors, and that's really important. Some of the features that we thought about and put in the plans is a nice cubicle workstation for the pharmacists for their actual validation of orders with the new computer system. A second area is a picking station just for the technicians, so they can have access to medications when they're filling orders, and putting them set aside with the workflow to be double checked by a pharmacist before going out into the pharmacy. And it's all in the workflow and design, which we're trying to keep in mind. We also have a separate area in plan, a computer and a printer for when we're unit dosing and barcoding medications, away from everything without being distracted and interrupted. We also have two other areas for an OR exchange tray, where we have medications in trays that go up on a daily basis to the anesthesia in the OR on a daily basis. We have a whole segregated area with designs that have the trays and the medications just for the anesthesia trays, which are supposed to be going in there, so there's no any errors in that in the trays. And last but not least, a nice area dedicated for controlled substances coming from our computerized safe, where they're double checked by a pharmacist and it's under surveillance and then everything is being watched, and they get signed and they go out for dispensing out on the floors.
Sounds like every detail of
a
medication dispensing and
lot of
management
one.
is being thought through.
And not only that, I mean, my assistant director and myself went to these areas, but we took a lot of this information, and we have a wonderful group of pharmacists and technicians, because they're really truly the end users. And we asked them, what do you think? What would work? What doesn't work? You know, because it's really important, because they're doing it day in, day out, and we needed that feedback, and it was really important. And for them, they were just totally thrilled that we were actually including them in some of the decision making. I mean, for example, the hands-free sink was a great idea that came from one of our pharmacists. Why do we have to turn on, after we gown up and put our gloves on after we wash our hands, why do we have to turn the faucets off? So
Best ideas always come from the people actually
Exactly.
doing the work. And I know we're just about out of time, but I know one of the other things I wanted to emphasize is that the pharmacy and the role of We Train Young Physicians, the education role that you play is enormous in getting the physicians up to speed. And one sort of public relations plea I'd like to make is, why not flush stuff down the toilet? That used to be the old. To be the old wisdom. Get rid of your medications, flush them down the toilet.
Yes.
Why not? And what are we doing about it now?
Yes. That is an extremely important topic, not only for the community and the residents in our community, but also for our hospital. In the hospital setting, and also for the community, we should not be putting any medications down the toilet. Not only that, they've been put in garbages, they've been put in the toilet. Those medications that get put in the garbage, other people can get hands on them, they can use them, and they could be affected in many different ways. But in the hospital, we have a system set up in place that any expired, controlled, and non-controlled substances go through. We have a reverse distributor that works with our wholesaler, and we get some credit for those medications. And in those medications that are partially used, and then we have remnants of those medications left over, we have a waste management company that disposes them appropriately and accordingly to all the rules and EPA standards. For the community, it's very important that they don't flush these medications down the toilet, because who knows where they wind up. There's justification saying they wind up in our water table, and they can affect any type of, anyone coming in contact with that. And with that being said, there's several retail community pharmacies have take-back programs, which they have throughout the year, and that's very important, where anyone, and it's not even their medication, that they can get rid of them and dispose of them, whether it's medication, syringes, needles, insulins, and they can get them out of the household, whether it, help protect children, protect anyone else from taking someone else's medication. In addition to that, the county has been really proactive in working with the local police stations, where they've actually put disposal boxes where anyone at any point in time can go to a police station, and in that box just dispose of unwanted medications, and that's really important too. And just recently, Southampton has sponsored a police box at the Southampton Village Police Station.
That's right. So we certainly don't want people keeping old medications in the house, but
Absolutely.
dispose of them properly, I guess is the message. Well, Jerry, thank you very, very much for all the great work you're doing.
Thank you.
Certainly we can sleep safer, sounder at night, knowing that our medication dispensing process is just getting safer and safer. Thank you very much to you and your team. And I'd like to thank all of you for watching this afternoon, and I'd like to thank our friends, as always, at CTV for producing and airing this show in Southampton, and our friends at LTV for airing it in our East Hampton communities. If any of you have any questions or would like additional information from our pharmacy staff, please feel free to call my office at 631-726-8555, even if you need help navigating our health system here on the East End. Once again, thank you everyone for listening, and keep sending us your ideas for new programs in the future. Good health, everyone.